Hematological manifestations in systemic lupus erythematosus, SLE, are common and often contribute significantly to the disease's morbidity. The hematological abnormalities in SLE primarily involve red blood cells, white blood cells, and platelets. Here's a brief overview of the key aspects. HAR1. Anemia. Anemia of chronic disease. This is the most common type of anemia in SLE, associated with the chronic inflammation seen in lupus. Autoimmune hemolytic anemia, AIHA, due to autoantibodies targeting red blood cells, leading to their destruction. Iron deficiency anemia can result from chronic gastrointestinal bleeding, often secondary to NSAID use. Anemia secondary to renal failure occurs due to decreased erythropoietin production in lupus nephritis. 2. Leukopenia, lymphopenia. Low lymphocyte count is the most common white blood cell abnormality in SLE and is often associated with disease activity. Neutropenia. Mild to moderate neutropenia can be seen, though severe neutropenia is less common. It can be caused by the disease itself or secondary to medications like immunosuppressants. HAP3. Thrombocytopenia. Common in SLE and may result from immune-mediated destruction of platelets, similar to ITP, idiopathic thrombocytopenic purpura. Severe thrombocytopenia can cause mucocutaneous bleeding or more serious hemorrhage. Najer-4, antiphospholipid syndrome, APS. A significant overlap exists between SLE and APS, where patients develop antiphospholipid antibodies, APL. APS is associated with a risk of thrombosis, both arterial and venous, and recurrent pregnancy loss. Laboratory findings include the presence of lupus anticoagulant, anticardiolipin antibodies, and anti-BT2 glycoprotein 1 antibodies. 5. Bone marrow involvement. Bone marrow biopsies in SLE can show various abnormalities, such as hypocellularity, myelofibrosis, or even hemophagocytosis. Macrophage activation syndrome, MAS, a form of hemophagocytic lymphohistiocytosis, HLH, can occasionally occur in SLE. 6. Other hematological manifestations. Thrombotic microangiopathy, TMA. This can occur in lupus nephritis or APS, presenting as a combination of thrombocytopenia, microangiopathic hemolytic anemia, and organ dysfunction. Elevated ESR, commonly seen in active SLE due to chronic inflammation. Hematological manifestations in SLE often require a combination of disease-modifying agents like corticosteroids, immunosuppressants, e.g. azathioprine, mycophenolate, and biologics, e.g. belimumab, rituximab, depending on the severity and underlying pathology. Pancytopenia and bicytopenia are hematological manifestations of systemic lupus erythematosus, SLE, and represent reductions in multiple cell lines, which may be indicative of severe disease or related to drug treatments. Let's explore each in more detail. HATR1. Pancytopenia in SLE. Pancytopenia refers to the reduction in all three blood cell lines: red blood cells, anemia; white blood cells, leukopenia; and platelets, thrombocytopenia. The pathogenesis is multifactorial, involving both immune and non-immune mechanisms. Causes of pancytopenia in SLE. Bone marrow suppression. The immune system attacks the bone marrow, causing reduced production of blood cells. This may be exacerbated by medications like immunosuppressants or cytotoxic agents, e.g. cyclophosphamide, azathioprine. Peripheral destruction. Autoimmune destruction of blood cells due to autoantibodies, e.g. anti-RBC antibodies, antiplatelet antibodies, is common. Infections. SLE patients are prone to infections, which can exacerbate pancytopenia through bone marrow suppression or sepsis-related destruction of cells. Hypersplenism. Splenomegaly may lead to increased sequestration and destruction of blood cells in the spleen. Hemophagocytic lymphohistiocytosis, HLH, or macrophage activation syndrome, AS. These are rare but life-threatening syndromes where activated macrophages engulf blood cells, leading to severe pancytopenia. Drug-induced. Medications like cytotoxic agents, mycophenolate mofetil, and even corticosteroids can sometimes lead to marrow suppression and pancytopenia. Clinical features: anemia, fatigue, pallor, and sometimes shortness of breath. Leukopenia, increased risk of infections. Thrombocytopenia, easy bruising, bleeding tendencies, e.g. epistaxis, petechiae, mucosal bleeding. Treatment: immunosuppressive therapy. Corticosteroids, azathioprine, or mycophenolate mofetil are often used to suppress the autoimmune destruction of blood cells. IVIG, intravenous immunoglobulin, may be used in severe immune-mediated cytopenias. Plasmapheresis, used in refractory cases, especially in severe autoimmune hemolytic anemia. Biologics, rituximab or belimumab can be considered in resistant cases. Infections need to be treated aggressively given the immunocompromised state of SLE patients. 2. Bicytopenia in SLE. Bicytopenia involves the reduction in two of the three blood cell lines, e.g., anemia with thrombocytopenia or leukopenia with thrombocytopenia. The mechanisms are similar to those of pancytopenia, but usually less severe. Causes of bicytopenia. Autoimmune destruction. Similar to pancytopenia, autoantibodies can target red blood cells and platelets simultaneously, e.g., in Evans syndrome, where autoimmune hemolytic anemia occurs with immune thrombocytopenia. Drug-related, certain medications, including methotrexate, cyclophosphamide, and azathioprine, may suppress more than one cell line. Infections. Viral infections, e.g. CMV, parvovirus B19, Epstein-Barr virus, or bacterial sepsis can result in bicytopenia, often leukopenia and thrombocytopenia. Bone marrow involvement. Bone marrow suppression or fibrosis may selectively affect two cell lines. Clinical features depend on the specific cell lines affected, but symptoms include those related to anemia, fatigue, leukopenia, infection risk, and thrombocytopenia, bleeding tendency. Treatment. Similar to pancytopenia, with a focus on immunosuppressive therapy to control the underlying autoimmune activity. Steroid-sparing agents, e.g. azathioprine, mycophenolate, are used in chronic cases. Biologic therapy. In cases of refractory autoimmune cytopenias, biologics like rituximab may be considered. Bone marrow support, granulocyte colony stimulating factor, GCSF, may be used to stimulate white blood cell production in cases of severe neutropenia. Diagnostic approach, blood smear and bone marrow examination, to assess whether the problem lies in the production, bone marrow, or peripheral destruction of cells. Autoantibody testing, direct antiglobulin test, DIAT, for hemolytic anemia, antiplatelet antibodies for thrombocytopenia. Infection screening, assess for underlying infections that could contribute to bone marrow suppression or destruction of blood cells. Bone marrow biopsy may be necessary in cases of refractory pancytopenia or when there is suspicion of bone marrow infiltration, e.g. due to lupus infection or malignancy. In summary, pancytopenia and bicytopenia in SLE are serious manifestations that often indicate active or severe disease. Treatment primarily involves controlling the underlying lupus activity and addressing complications such as infections or drug-induced cytopenias. Yes, it is possible for an infection to mask pancytopenia by temporarily increasing the white blood cell WBC count, resulting in what appears to be bicytopenia, anemia, and thrombocytopenia. Here's how this can happen. Mechanism of infection. Masking pancytopenia. 1. Leukocytosis, increased white blood cells. Due to infection. Infections, particularly bacterial infections, can trigger an immune response that leads to leukocytosis, an elevation in the white blood cell count. This is especially true in acute bacterial infections, where the body's response to infection involves increasing WBC production to fight off the invading pathogens. Even though the patient might have underlying bone marrow suppression or autoimmune leukopenia due to SLE, the infection can cause a transient rise in the WBC count, leading to normal or elevated WBC levels on a complete blood count, CBC. Number 2, masking of pancytopenia. Since pancytopenia refers to reductions in all three cell lines, red blood cells, white blood cells, and platelets, if the infection increases the WBC count, the low white cell count might no longer be apparent. As a result, the CBC may show only anemia and thrombocytopenia, which may be interpreted as bicytopenia rather than pancytopenia. Once the infection resolves and leukocytosis subsides, the underlying leukopenia may become evident again, unmasking the true pancytopenia. Clinical implications, careful interpretation. In SLE patients, clinicians should be cautious when interpreting CBC results during an infection, as the WBC count may not reflect the true underlying hematologic status. Reevaluation after infection. Once the infection is controlled, a repeat CBC should be performed to reassess the white blood cell count and determine if pancytopenia is present. This is especially important because missing pancytopenia could delay the diagnosis of severe bone marrow involvement or an underlying immune mediated process. Infection induced leukocytosis. It's important to remember that leukocytosis due to infection is typically reactive and temporary. It does not eliminate the underlying risk of cytopenias related to SLE. Diagnostic approach. Peripheral blood smear. This can help assess the presence of abnormal or immature white blood cells, which may suggest a reactive process due to infection. Bone marrow evaluation. In unclear cases, particularly in the context of pancytopenia, a bone marrow biopsy may be needed to evaluate for marrow suppression, infiltration, or other causes. Follow-up testing. Post-infection CBC testing can help confirm whether the WBC count returns to a leukopenic state, indicative of underlying pancytopenia. In summary, an infection can indeed the WBC count and mask pancytopenia, making the CBC appear closer to bicytopenia, anemia, and thrombocytopenia. Careful follow-up and reassessment are key to detecting the true extent of hematological involvement in SLE. In systemic lupus erythematosus, SLE, drug-induced hematological abnormalities are common, given the extensive use of immunosuppressive, anti-inflammatory, and cytotoxic drugs. These medications can affect different cell lines, leading to anemia, leukopenia, thrombocytopenia, or pancytopenia. Here's a detailed overview of the drugs commonly used in SLE that can cause hematological abnormalities. Number 1. Corticosteroids, e.g. prednisone. Leukocytosis. Corticosteroids can cause an increase in neutrophil count due to demargination, release of neutrophils from the vessel walls into circulation, though they may mask leukopenia caused by SLE or other drugs. Lymphopenia. Chronic steroid use can lead to a reduction in lymphocytes, exacerbating the lymphopenia often seen in SLE. Anemia and thrombocytopenia. Prolonged use can lead to bone marrow suppression, especially at high doses or in combination with other drugs. 2. Cyclophosphamide, pancytopenia. This alkylating agent is commonly used in severe SLE, especially lupus nephritis or neuropsychiatric lupus, and can cause bone marrow suppression leading to pancytopenia. The effect is dose-dependent and cumulative. Leukopenia and neutropenia. Neutropenia is a well-known complication of cyclophosphamide, which increases the risk of infections. Thrombocytopenia. Less common, but can occur as part of general bone marrow suppression. Hemorrhagic cystitis. Though not a hematologic abnormality, it is a severe complication that can lead to blood loss, hematuria. 3. Azathioprine. Leukopenia and neutropenia. This drug can cause bone marrow suppression, particularly neutropenia, which is related to its effects on DNA synthesis. Patients with TPMT, thiopurine methyltransferase, deficiency are at a higher risk for severe myelosuppression. Anemia and thrombocytopenia. Vazaprine can cause pancytopenia, especially at higher doses or in combination with other myelosuppressive drugs. Macrocytosis. A mild macrocytic anemia can be seen with azathioprine due to effects on DNA synthesis. 4. Mycophenolate mofetil, MMF. Leukopenia and neutropenia. MMF, used frequently in lupus nephritis, can cause significant neutropenia by inhibiting DNA synthesis in white blood cells. Anemia. It can also cause anemia, typically due to bone marrow suppression or hemolysis in rare cases. Thrombocytopenia can occur, although less commonly than neutropenia. Pancytopenia, especially in patients who are on combination therapy with other immunosuppressive agents. 5. Methotrexate, pancytopenia. This drug, used in SLE for its immunomodulatory effects, can cause pancytopenia by inhibiting folate metabolism, which is essential for DNA synthesis. Leukopenia and neutropenia. Methotrexate often causes neutropenia, putting patients at risk of infection. Anemia and macrocytosis. Macrocytic anemia is common due to folate antagonism, and folic acid supplementation is usually given to mitigate this risk. Thrombocytopenia. Platelet counts may also be affected in the setting of methotrexate-induced bone marrow suppression. Number 6. Hydroxychloroquine, thrombocytopenia. Although generally safe, hydroxychloroquine has been associated with immune thrombocytopenia in some patients. Leukopenia, rare, but it can cause agranulocytosis or mild leukopenia in some cases. Hemolytic anemia in G6PD deficiency. Hydroxychloroquine can cause hemolytic anemia in individuals with glucose 6 phosphate dehydrogenase (G6PD) deficiency. Belimumab, leukopenia. This biologic targeting B cell survival may cause mild to moderate leukopenia, particularly lymphopenia, though it is generally well tolerated in terms of hematological side effects. Increased infection risk. Though it does not directly cause pancytopenia, it can lead to an increased risk of infections, which may exacerbate pre-existing leukopenia. 8. Rituximab, leukopenia and neutropenia. While rituximab primarily targets B cells, it can cause late-onset neutropenia, occurring weeks or months after therapy, as well as transient leukopenia. Pancytopenia. Rare cases of pancytopenia have been reported, especially when used in combination with other cytotoxic agents. 9. NSAIDs, anemia. Chronic use of NSAIDs, nonsteroidal anti-inflammatory drugs, can cause iron deficiency anemia due to gastrointestinal bleeding. Thrombocytopenia. Rarely, NSAIDs can cause thrombocytopenia due to immune-mediated destruction of platelets. Aplastic anemia. Though rare, some NSAIDs have been linked to aplastic anemia, a severe form of bone marrow failure. 10. Sulfasalazine, leukopenia and agranulocytosis. Sulfasalazine, used in some cases of SLE, can cause significant leukopenia or even agranulocytosis, which requires regular monitoring of blood counts. Hemolytic anemia in G6PD deficiency. Like hydroxychloroquine, sulfasalazine can trigger hemolytic anemia in individuals with G6PD deficiency. Thrombocytopenia. Immune-mediated thrombocytopenia has also been reported. Preventive measures and monitoring. Regular CBC monitoring. Close monitoring of complete blood counts, CBC, is essential for early detection of drug-induced hematological abnormalities. Frequency of testing depends on the drug used and the clinical context, e.g., every 1 to 3 months for azathioprine or mycophenolate. Folic acid supplementation. This is often recommended for patients on methotrexate to reduce the risk of macrocytic anemia and pancytopenia. TPMT testing. Before starting azathioprine, testing for TPMT activity may identify patients at high risk for myelosuppression. G6PD screening. Screening for G6PD deficiency is important before initiating drugs like hydroxychloroquine or sulfasalazine to prevent hemolytic anemia. Conclusion. In SLE, drug-induced hematological abnormalities are common and can range from mild cytopenias to life-threatening pancytopenia. Careful selection of medications, regular blood monitoring, and timely intervention are crucial to managing these side effects while balancing the need to control lupus activity. In patients with systemic lupus erythematosus, SLE, hematological abnormalities are common and can arise from various causes, including disease activity, infection, drug-induced cytopenias, or other causes such as malignancy or bone marrow failure syndromes. Differentiating between these causes is crucial for appropriate management. Here's how to approach the differential diagnosis of hematological abnormalities in SLE. Number 1. SLE disease activity. Hematological abnormalities in active SLE are often due to the autoimmune destruction of blood cells, which can manifest as anemia, often hemolytic or anemia of chronic disease, leukopenia, particularly lymphopenia and neutropenia, thrombocytopenia, immune-mediated, or pancytopenia, less common but possible in severe cases. Clues. Suggestive of active SLE. Other systemic features. Concomitant lupus flares involving joints, skin, e.g. rash, kidneys, e.g. lupus nephritis, or CNS involvement. Autoimmune hemolytic anemia, AIHA, presence of positive direct Coombs test, DA, reticulocytosis, elevated LDH, indirect hyperbilirubinemia, and decreased haptoglobin. Leukopenia, particularly lymphopenia, which correlates with disease activity. Thrombocytopenia, due to immune-mediated platelet destruction, often associated with antiphospholipid antibodies, APS. Elevated ESR. ESR is usually elevated in active SLE, whereas C-reactive protein, CRP, is not significantly elevated unless there is an infection. Diagnosis. Autoantibodies. Look for SLE-specific autoantibodies, ANA, anti-dsDNA, and complement levels, C3, C4, that may be low during disease activity. Bone marrow biopsy may show normal cellularity or hypercellularity with increased megakaryocytes in immune thrombocytopenia. Infection. Infections are common in SLE due to immune system dysfunction and immunosuppressive therapy, and they can cause a wide range of hematological abnormalities. Leukocytosis, typically seen in bacterial infections. Leukopenia may be present in viral infections or sepsis. Anemia can result from chronic infections, sepsis-related hemolysis, or direct bone marrow suppression. Thrombocytopenia, seen in sepsis due to DIC or viral infections, e.g. EBV, CMV, parvovirus B19. Clues suggestive of infection: fever and systemic symptoms, unexplained fever, chills, or signs of localized infection, e.g. respiratory, urinary. CRP, elevated CRP is more specific for infection rather than lupus activity. Blood cultures should be obtained in the context of febrile neutropenia or suspected sepsis. Bone marrow may show signs of bone marrow suppression or infiltration by pathogens, e.g. mycobacterial or fungal infections. Diagnosis: blood cultures, viral serologies, EBV, CMV, parvovirus, PCR for viral infections. Chest X-ray, CT scan, or other imaging to localize the infection. Bone marrow biopsy in case of profound and unexplained cytopenias, particularly if there's suspicion of opportunistic infections, e.g. fungal tuberculosis. 3. Drug-induced hematological abnormalities. Many medications used in the treatment of SLE can cause hematological abnormalities through bone marrow suppression or immune-mediated mechanisms. Pancytopenia can result from cytotoxic agents like cyclophosphamide, methotrexate, and azathioprine. Leukopenia neutropenia, commonly seen with azathioprine, mycophenolate mofetil, methotrexate, and hydroxychloroquine. Thrombocytopenia, seen with many drugs including hydroxychloroquine and NSAIDs. Hemolytic anemia, certain drugs, e.g. sulfasalazine, hydroxychloroquine, can cause hemolysis, especially in patients with G6PD deficiency. Clues suggestive of drug-induced cytopenia. Temporal relationship. Symptoms may begin after starting or increasing the dose of a new medication. Bone marrow suppression. Drugs like azathioprine and methotrexate can cause bone marrow suppression, leading to pancytopenia, particularly in patients with TPMT deficiency. Resolution on drug withdrawal. Stopping the offending drug typically leads to gradual improvement in blood counts. Diagnosis: medication review. Consider recent changes in medications, particularly cytotoxic drugs or those known to affect the bone marrow. Bone marrow biopsy may show hypocellularity or aplasia in drug-induced marrow suppression. TPMT activity. For patients on azathioprine, checking TPMT levels can help identify those at higher risk for myelosuppression. 4. Other causes. Several other conditions, not related to SLE activity or its treatment, can cause hematological abnormalities. Bone marrow failure syndromes, aplastic anemia, can occur independently or due to drugs, infections, or autoimmune processes. Presents with pancytopenia and hypocellular marrow. Myelodysplastic syndromes, MDS, can present with cytopenias in older SLE patients or those exposed to cytotoxic therapy. HAIR-B, hemophagocytic lymphohistiocytosis, HLH, or macrophage activation syndrome. Rare but life-threatening conditions characterized by severe pancytopenia, high ferritin, elevated triglycerides, low fibrinogen, and evidence of hemophagocytosis on bone marrow biopsy. C. Antiphospholipid syndrome, APS, can cause thrombocytopenia and, in severe cases, thrombotic microangiopathy, TMA, which can present with hemolytic anemia, thrombocytopenia, and acute renal failure. D. Malignancy, lymphoma or leukemia. Some patients with SLE are at increased risk of malignancy, particularly lymphoma, which can present with cytopenias due to marrow infiltration. Diagnosis: bone marrow biopsy to assess for primary bone marrow failure or malignancy. Ferritin, triglycerides, fibrinogen for suspected HLH or mass. Flow cytometry to evaluate for hematologic malignancies. Summary of diagnostic approach. 1. Clinical history. Evaluate for recent infections, drug changes, or signs of SLE flare. 2. Lab tests, autoimmune markers, ANA, anti-dsDNA, complement levels for SLE activity. Infection markers, blood cultures, CRP, procalcitonin, viral PCRs for infections. CBC with differential, reticulocyte count, direct Coombs test, LDH, haptoglobin, and bilirubin to assess hemolysis. 3. Bone marrow biopsy for unexplained or persistent cytopenias, particularly if suspecting bone marrow failure, HLH, or malignancy. for imaging and cultures, as indicated for infection workup. Differentiating the cause of hematological abnormalities in SLE requires a comprehensive evaluation of clinical history, laboratory findings, and sometimes bone marrow biopsy. Correct identification of the underlying cause is essential for guiding appropriate treatment. Schematic approach to the management of hematological abnormalities in systemic lupus erythematosus, SLE. A structured approach to hematological abnormalities in SLE involves careful assessment of the underlying cause, e.g., disease activity, infection, drug toxicity, or other conditions, and tailored management based on updated guidelines. Step 1. Patient evaluation and initial workup. 1. History and physical examination. Assess for signs of active SLE, e.g., rash, arthritis, nephritis, infection, e.g., fever, localized signs, recent drug use, or other conditions like thrombosis for antiphospholipid syndrome, APS. 2. Laboratory tests. Complete blood count, CBC, with differential. Identify the type of cytopenia, leukopenia, thrombocytopenia, or pancytopenia. Reticulocyte count to evaluate bone marrow response in anemia. Peripheral blood smear to assess for hemolysis, abnormal cells suggestive of malignancy or infection. Markers of hemolysis, LDH, indirect bilirubin, haptoglobin, and Coombs test, direct antiglobulin test for autoimmune hemolytic anemia. Infection workup, CRP, blood cultures, viral PCR, EBV, CMV, parvovirus, and serologies. Autoimmune markers, AN, anti-dsDNA, complement, C3, C4 levels. Bone marrow biopsy, indicated in cases of unexplained pancytopenia, suspected malignancy, or aplastic anemia. Step 2. Categorizing the cause. SLE disease activity, cytopenia type, leukopenia, mainly lymphopenia, autoimmune hemolytic anemia, immune thrombocytopenia. Labs, positive ANA, anti-dsDNA, low complement, positive Coombs test. Management, immunosuppressive therapy based on severity. B. Infection. Cytopenia type, leukopenia, viral, neutrophilia, bacterial, pancytopenia, and sepsis. Labs, elevated CRP, procalcitonin, positive cultures, or viral serologies. Management, antibiotics or antivirals based on the pathogen and hold or reduce immunosuppression. C. Drug-induced. Cytopenia type. Can affect any or all cell lines, pancytopenia, leukopenia, thrombocytopenia. Clues, onset after starting drugs like azathioprine, mycophenolate, methotrexate, or cyclophosphamide. Management, discontinue or adjust the drug, monitor blood counts, and consider bone marrow stimulating agents if severe. D. Other causes, e.g. HLH, APS, malignancy, aplastic anemia. HLH, severe pancytopenia, high ferritin, splenomegaly. APS, thrombocytopenia with thrombosis, positive antiphospholipid antibodies. Malignancy, persistent cytopenias with abnormal cells on smear or bone marrow. Management, specific to each condition, HLH protocols, anticoagulation for APS, chemotherapy for malignancy. Management of hematological abnormalities based on guidelines. 1. Anemia, autoimmune hemolytic anemia, AIHA. First line, glucocorticoids, e.g. prednisone 1 to 2 milligrams kg day. Steroid-sparing agents, rituximab, azathioprine, or mycophenolate mofetil if steroid refractory. Severe refractory cases, IVIG, or splenectomy. Anemia of chronic disease, ACD. Management. Treat underlying lupus activity. Erythropoiesis-stimulating agents, ESAs, if severe anemia and no response to lupus-directed therapy. Iron deficiency anemia due to GI bleeding from NSAIDs. Management. Iron supplementation and NSAID cessation. 2. Leukopenia neutropenia. SLE-related, often mild and does not require specific treatment. If severe, neutrophils 1000 milliliters, consider low-dose steroids or immunosuppressive agents, e.g. mycophenolate, azathioprine. Drug-induced neutropenia. Discontinue the offending agent. GCSF, granulocyte colony-stimulating factor, can be considered in cases of severe neutropenia. Infection-related. Manage underlying infection, antibiotics, antivirals, and reduce immunosuppression if possible. Thrombocytopenia, immune thrombocytopenia, ITP. First line, glucocorticoids, e.g. prednisone or IV methylprednisolone. Second line, IVIG, intravenous immunoglobulin, or rituximab. Refractory cases, splenectomy or thrombopoietin receptor agonists, e.g. L-trombopag. Thrombotic thrombocytopenic PERT TTP, microangiopathic hemolytic anemia, MACA, plasma exchange and immunosuppressive therapy. Antiphospholipid syndrome, APS, related thrombocytopenia, low-dose aspirin and anticoagulation for thrombotic risk, rituximab or cyclophosphamide for refractory thrombocytopenia. 4. Pancytopenia, bone marrow suppression, drug-induced. Discontinue the causative drug. Bone marrow stimulants, GCSF or EPO for leukopenia and anemia, respectively. Severe lupus-related pancytopenia, high-dose steroids, e.g. IV methylprednisolone. Steroid-sparing agents, cyclophosphamide, rituximab, or mycophenolate. Hemophagocytic lymphohistiocytosis, HLH, macrophage activation syndrome, aggressive immunosuppression, high-dose steroids, cyclophosphamide, rituximab, and HLH-specific therapy, e.g. etoposide-based regimens. NASH updated guidelines and recommendations, 2020-2024, from the EULAR and ACR 2019-2022 guidelines. Steroid-sparing strategies. Avoid prolonged steroid use by incorporating early use of immunosuppressive agents like rituximab, mycophenolate, or azathioprine. Infections. SLE patients are at higher risk of infection, especially with immunosuppressive treatment. Active infections should be treated promptly, and clinicians should consider holding immunosuppression during severe infections. Vaccinations. Ensure appropriate vaccinations, especially pneumococcal, influenza, and hepatitis B, before initiating immunosuppression. GCSF and EPO. Use these agents cautiously in cases of severe leukopenia or anemia, but avoid long-term reliance unless absolutely necessary. Monitoring. Regular CBC monitoring is recommended for all patients receiving immunosuppressive therapy, particularly in the first months after initiating treatment. Frequency can vary from every 1 to 3 months based on drug and disease severity. Multidisciplinary approach. Collaborate with hematologists when there are overlapping syndromes, e.g. HLH malignancy, or when standard treatment fails. Schematic approach summary. 1. Assess. Determine if hematological abnormalities are due to disease activity, infection, drugs, or other causes. 2. Investigate. Perform thorough clinical and laboratory evaluations, including CBC, peripheral smear, infection workup, autoimmune markers, and bone marrow biopsy when indicated. 3. Manage. Tailor therapy based on the underlying cause. Adjust immunosuppressive therapy for active disease, treat infections, discontinue offending drugs, and consider hematopoietic growth factors for severe cases. 4. Monitor. Frequent CBC and clinical follow-up are essential, especially during changes in therapy or new infections. This systematic approach aligns with the latest guidelines for the effective management of hematological abnormalities in SLE patients.